movie either, but I'm going to go for it. Anybody see the movie Signs? Oh my gosh, I had some people say yes. Those that see no, well, guess what your little thing's going to be? I'm going to just add it to the list of movies that you're going to have to watch. So Signs is with Mel Gibson. It's an M. Night Shyamalan movie. And at one point in the movie, at the end, you really have to see it. But the little boy is being held together or held by the alien. I know it sounds a little freaky. But anyway, the alien has his little gas. The kid, the night before, had an asthma attack and didn't have his nebulizer. And it's a really cool part to explain what about asthma. The alien puts up his gas, and the gas goes into the patient, into the little boy's nose. Then some things. I'm going to have to pull up the video. That's all.
I watched the beginning of that.
You watched the beginning of that?
I didn't finish it.
Oh, you should finish it. And now I'm going to have to watch the video. But anyway, the whole reason that the little boy doesn't die from the alien gas is due to the fact that he has asthma. So as the gas goes in, it's not going anywhere. So he doesn't inhale it, which is really kind of cool. And that's what really shows what asthma is. It's not allowing the air, the oxygen to get into the lungs. Okay. Later on, when we're talking about COPD, that's not allowing the air to exit. And that's why you have the barrel chest. But we'll talk about that in 3 pages from now. Okay, so what causes the airways to narrow? Yes, I have the board.
The inflammatory response.
What was that?
The inflammatory response.
Okay, so what would cause that inflammatory response?
Histamine is released.
Okay. So inflammatory, so that's almost like an allergic reaction, right? If you think about it, I mean, that's what happens in an allergic reaction. So what could cause somebody to have an asthma attack?
Allergens.
Allergens could be anything, right? It could be
exercise induced.
Exercise induced. I generally call that being out of shape, but anyway.
So why don't they get hives? Is that a different receptor?
Yes. It would be a different receptor. What's interesting though, it is, but it isn't, because you can use, if you have hives, you can actually use Claritin for your hives. In the same aspect, you can use Pepcid for your hives because it's H2 receptor antagonist. So you can use those different things for hives, so to speak. But it's just how your body is reacting to those histamines. Instead of hives, you have bronchial issues. We talked about triggers. What are some manifestations?
Wheezing.
Wheezing.
Chest tightness, cough, dyspnea, tachypnea.
Okay, very good. Does diminished breath sounds mean the patient's getting better?
Nope.
No. So if you're like, say you're hanging out in the ER and you know somebody's having an asthma attack and you can hear the wheezing going on. And if you walk past and you hear the wheezing, then you go past again and you don't hear the wheezing so much, you can't exactly say, well, oh, they must be getting better. What could be happening is they're going into respiratory failure. So don't equate, lack of wheezing to getting better. Okay.
Hey, Becky.
Yes.
Sorry, I have a question. It could technically also mean that they are getting better though, right? Like it doesn't necessarily mean that they're going into respiratory failure, right?
So what I would do is listen to their lungs. I wouldn't listen from outside the door.
So if you went in and you heard how would you differentiate? Would you see like respiratory like depression or what? How would you differentiate if it's getting better or worse?
If you listen to the lung sounds and you don't hear any air movement, then you know it's getting worse. But if you start hearing they're not if they're not to, I hate to say tachypenic, but if they're breathing normally, then you know they're getting better. If they're still tachypenic, even no, that's not even right, because you figure when you're getting respiratory depression, you're going to start, your breathing's going to slow down. So one of the, I would say the biggest way is just to listen to their lung bases. If you hear air movement, then they're getting better. If they're not blue, you know, they're getting better. You know, if their LOC is normal, you know, they're getting better. So it's, I just don't want you to go past the door and say, oh, they're getting better without checking the situation out, without assessing them.
Would we expect them to be unresponsive at that point, or does it just depend?
I would say the level, they might still be responsive, but their LOC will be decreased. Because by that time they're going to respiratory depression. We got to do something like now. Like now. Does that help?
Yes, thank
Okay. How is cough variant asthma different?
They still have a cough, but they don't have dyspnea or wheezing.
Yep, that's it. That's the only difference. And what are some complications of asthma?
Status asthmaticus, dehydration, respiratory infection, atelectasis, pneumothorax, and cor pulmonale.
So what would you think? Do you think we see a lot of asthmatics on our unit?
No,
Why would you say that?
I feel like a lot of them are in the emergency room, and then like for acute or like acute asthma attacks, unless it gets into a complication.
That's it. Usually they can go into emergency room and they basically treat them and street them. They can get them in, get the acute attack taken care of, and then they'll put them back. They'll send them home. Very seldom do we have a patient that comes up to us that with an asthma attack. I would say if anything, they go to ICU because they're critical before we see them.
I have a question,
Yes.
Becky. Can you explain exactly what cor pulmonale is, please?
So cor pulmonale is when basically right-sided failure. So the blood is there's so little of I don't want to say surface. Let me see if I can explain this. There's so little surface that the blood and the oxygen can't exchange. And because of that lack of surface, there's more, the blood can't flow through, like can't get through the lungs back into the heart and back into the rest of the body. So what you end up having is basically right-sided failure because the blood backs into, and that's why you have the distended neck veins. Basically, you'll start seeing splenomegaly and hepatogamy and your edema, okay, because of the fact that it's so much damage, so much constriction, it just can't flow. Like it goes into the lungs, but just can't get out. So that's where you're stuck at. So everything backs up behind it. Does that make sense? Is there a lot of questions on cor pulmonale? No. Okay, which I'm sure that's what you really want to know.
Exactly.
You know, and we really don't see it. You know, you would have to be almost in a specialized unit to really see cor pulmonale, but it is fatal if it's not taken care of. And that's what, you know, when people have pulmonary hypertension, it goes into cor pulmonale, and that's what ultimately kills them, is that right-sided failure. Okay.
Karen kind of phrased it like it's right-sided heart failure caused by asthma.
By the pulmonary hypertension.
Yeah.
Okay. And then we talked status asthmaticus.
Severe prolonged asthma attack not responding to routine treatments. It might
Yeah.
lead to respiratory failure.
So those kind of people, when we can't get it to stop, we're eventually just going to have to intubate them and take care of it ourselves. Okay, how is asthma classified?
Frequency of symptoms, nighttime awakenings, like how many times they wake up throughout the night. Use of short acting, like how often they have to use their inhaler, interference of normal activity, and lung function per PFT values.
Okay, so this is what it means by this. If you go into, say you have asthma and you go to the doctor's office and the doctor office says, how's your asthma? How many times do you wake up at night? How many times do you have do you have to use your rescue inhaler? How many, are you able to do your ADLs? If you answer, well, I used my rescue inhaler like 8 times last week, and I wake up at night at least 3 times, they're going to say that you're uncontrolled. Your asthma is uncontrolled. So they're going to have to add something to your regimen to get you more under control. That rescue inhaler is not to be for you to live on, so to speak. It's supposed to rescue you, but we want to give you a maintenance so that you don't have to rely on that rescue inhaler. And that's what they mean about classified. How is asthma classified? Like, how many times do you have to use this? So if you go in and you say, well, I haven't used my rescue inhaler. In fact, it went bad. Well, that's good. I'm glad it went bad. Now we have to pay for a whole new other one, which is expensive. Or, I can do my activities daily living. In fact, I ran 26.2 miles. Awesome. Okay, they can go ahead and do that. We're not going to do anything, but it's when their life is being altered that we have to add another medication to it. Okay, how do we diagnose asthma? Is it with a CT scan?
No,
How do we do it?
with the PFT, the ABGs, and then the allergen skin test.
Yeah, so initially what we're going to do is a PFT test. We're going to see how, that's the definitive way of figuring out about the asthma. And that's how we're going to figure out if it's getting worse or if it's getting, if we're having it controlled. Has anybody done a PFT test? Some people get you go into a box basically, and what they'll do is they'll have you breathe, and then after you breathe and they did that test, then they'll give you like albuterol, and they'll have you breathe again. And if that albuterol helps you, that helps show that if it's able to help you breathe better, that's an indicator that you have asthma. It's usually in a box. People get claustrophobic on it. They do have it so you can get it in like a doctor's office, but it's not as accurate. Okay, so that's the only way. An allergen test tells you what could cause the asthmatic attack, and an ABG will show that there's not enough oxygen getting to the lungs, and that's how your ABGs will show. Okay, what is a peak expectorant flow rate meter?
It measures how much air can be forcefully exhaled.
Why is that important? Why do we care?
We can't necessarily measure how much they're breathing in, but we know how much they're breathing out because it should be equal. So if they can't get air in, we know because they can't get air out.
Okay. And what are we going to do with that information?
Tell them if they're like able to function normally throughout the day, or if they're gonna need or if it goes to caution where like they'll need steroids or antibiotic or like bronchodilators.
Right. And that's what we're going to do. we're going to sit there and if they're green, they're good to go, right? If they're yellow, that means they have to do some caution. Let's see what's going on. Let's stay away from our triggers and possibly add another medication to our regimen. And then red, they're screwed. Not really. They're not screwed. We will have a regimen for them so that they know what to take. They should probably call their doctor and probably get some steroids so that they don't have an attack. I was telling the clinical group today, I said I had somebody argue with me that you should do the peak flow meter, that if she works in an ER and they do peak flow meters when somebody's having an asthma attack before they give them albuterol. And I'm like, well, that makes no sense whatsoever. If you know they're having an asthma attack, why do you need a peak flow meter? Well, we do that. I'm like, I mean, you can see they're having an asthma attack. This is used to be at home. It's not meant to be used in a hospital. It's used to be meant at home so they don't get an asthmatic attack. What is some education we can give to patients to prevent exasperations?
Avoid triggers, control like dust, remove your carpets, and like put covers over your mattresses and pillows, do an air filter, and
Yep, that's it. Avoid the triggers. It's better to avoid the triggers than to, be around the triggers and have to use a rescue inhaler. What are some medications that will provide quick relief?
Albuterol, ipratropium, oral and IV corticosteroids, anticholinergics, and methylxanthines.
Very good. And what will help the patient not have any exasperation?
Preventative inhalers, so steroids.
Steroids. You know what's interesting? I just thought of this. Do we give magnesium for exasperations? We actually do, and I was thinking, like, you probably wouldn't see it. So back in the day when we didn't have the scanning of the pumps, if we were given magnesium, we'd have to pick non-OB, non-asthmatic. It would be med surge is what we'd have to pick, because the OB and the asthma went really fast. So we would always do the non-asthma ones, but I need to put that on in my PowerPoints. Okay. How do you administer an MDI?
You want them to shake it really good?
Shake it real good. Do they blow out?
exhale slowly first.
And then inhale, right? And how long do they hold?
10
10
seconds.
seconds.
Very good. What about a PDI?
Don't refrigerate it.
Well, that was my next one. You jumped the gun.
You want them to breathe in rapidly with the PDI instead of slowly.
Exactly. Can you name? I'm trying to think. With the PDI, what is important to know, I should say, when you're talking about PDI?
Don't swallow the pill.
Yes. I was precepting another school the one day. I had one of their students and he pulled all the medications, and then I'm like, he put them all in the cup, and I'm like, what's that? And he's like, I can't remember what it was. My brain. Anyway, it was for a PDI, and he was going to give it to him as a PO. I'm like, don't do that.
Is it a PDI or a DPI?
powder. DDI?
In the notes, I thought it said DPI.
It does say DPI in the notes.
Okay, so I lied. DPI.
It said dry powdered.
Makes sense instead of powder dry. Okay, my mistake. Either way, you don't refrigerate it. And what is a spacer?
It helps it to better disperse it into the lungs.
Why? Well, who would you give a spacer to?
Children.
Why?
Because it allows them to get more air in, like it's allowing them to like take a deeper breath, basically.
Yeah, it gives them a little bit more of an oomph. Some people have a hard time also putting their mouth over. So it helps them with more, I should say, better control. I gotta use that. I gotta find a spacer. I don't know if Casey has a spacer or not. Did she have a spacer when you guys took 109? Nobody
I
knows.
slept a lot.
Did you say you slept a lot? Oh, since then. I'm like,
Yeah.
ooh, I'm telling Casey, you slept in her class.
No.
I'll tell her anyway.
We're on top right.
I'm supposed to use a spacer with my inhaler, but I don't. So I have an unopened one somewhere. If I can find it, I'll bring it in. You can have it because I hate them. I don't like them. So I
Why
don't
don't
use
you
them.
like them?
I just don't. I feel like I'm not, I don't know. I just feel like I'm not even getting the medicine because like I don't know. It's because I can't taste it, which I know completely like cancels out everything, but I don't like it. So I don't use it.
So
It's for
why did
albuterol,
they
but I don't
why did-
like it. They just want me to use it.
why do they want you to use it though?
They say they want everyone to use it because it helps the medication get to the lungs better and work faster. They said it just is better to use it. And they said it's like less likely that you'll be able to get like with other inhalers, like get an infection in your mouth and stuff. They say you're supposed to do it, but
Really?
I don't.
I gotta look that
I
up.
hate them. Yeah, I don't know. He just told me that he gives them to all his patients with any inhaler that'll fit a spacer. So like not like Spiriva because they don't make a spacer for that. But yeah, I'm supposed to use them with my albuterol, but I don't. So I'll try to find it. I think it's somewhere in my bathroom, but you can have
Well,
it.
then I don't want you to come out. They go, how come you didn't? Well, I gave it to my instructor.
I won't
why I
say
don't
that. I'll
use
just
it.
feel like I lost it.
Well, I appreciate it if you do because
I'll look for it.
I really would appreciate that.
Okay, I'll look.
Okay, what's the leading cause of COPD?
Smoking.
Smoking.
Yeah, you know it. What are some other risk factors for COPD?
Air pollution, occupational exposure, airway infection, asthma, and genetic factors.
Yeah, and generally what we see is that smoking is the biggest one. It's always been the biggest one. Even I've had one patient in all these years that had COPD because her husband smoked 2 packs a day for like the last 20 years of his life. And what really sucked is that she had COPD and we were trying to give her steroids because she just couldn't breathe. I mean, she was sat in like mid 80s. And she was just huffing and puffing and she was just not doing so good. And she didn't want the steroids due to the fact that she was afraid of getting fat and afraid of the moon face and all this stuff. I'm like, geez, Louise. And so I had to tell her it's not going to be long term, it's just short term. But he would not quit smoking. We even said, even if you smoke, do it in a different room, he still wouldn't do it. He said it was his house and therefore he's going to do whatever he wants in his damn house. And I guess that included kill his wife. So anyway, what disease processes consist of COPD?
Chronic bronchitis and emphysema.
Yeah, it's kind of like, it's almost like a syndrome. I wouldn't say syndrome, but it's those two processes that make up COPD. Okay. So what happens in chronic bronchitis?
There's an abnormal increase in mucosal secretions cells and the cilia function is impaired.
Okay. And well, that gets me into what is a mucus plug.
Unable to move the secretions up to be coughed.
Okay, so that's what happens with COPD. Part of it is the secretions. So when patients come in and they have an exacerbation of COPD, that's what they're having a problems with, is the chronic bronchitis part. Okay, they're unable to cough that mucus up. They have an extraordinary large amount of mucus, and therefore that's why they come into us, and that's why we're giving them steroids. So we'll give them antibiotics so that that mucus doesn't doesn't have the bacteria, so they don't get pneumonia, and then we'll give them steroids to decrease the inflammation. Remember, when we decrease the inflammation, we decrease the mucus production.
So if you have COPD, do you have chronic bronchitis automatic, like, and
So they
emphysema?
won't. So you can have chronic bronchitis without having COPD, but it's a chronic bronchitis is a
But-
factor of COPD.
But can you have COPD without having
No.
chronic? Okay.
No, those two things make it COPD. So you have their production, and with it, we'll get into emphysema. Those two things make COPD happen.
So
you
you
can
have
have one. You can have chronic bronchitis without having COPD. You can have emphysema without having COPD, but both of those together make COPD. Okay, so what are the manifestations of chronic bronchitis?
Persistent productive cough, wheezing, symptoms of pulmonary hypertension and right-sided heart failure.
Right.
Copious sputum, the purulent sputum.
Purulent sputum, exactly. So with so what do you think would it be a patient teaching with somebody that has chronic bronchitis?
Don't take cough syrup.
Yeah, that's one thing.
Drink a lot of water.
Water helps. What else do you think? Well, let's talk about real quick cough syrup. How does cough syrup work? Does it numb the throat so it doesn't, you don't feel like you have to cough? Or is it a magical item that when you take it,
It's
magic? So what cough syrup does is actually, I don't want to say numb, but it interacts with the cough center of your brain actually. That's what causes you not to cough anymore. Okay. So it's not something that just coats your throat and so you're not going to have to cough anymore. It actually goes into your brain, the cough center of your brain. So we don't want them to take the cough syrup because we want them to cough everything out. We want them to take to drink water. You might want to make sure they drink water, not like Monster or anything like that. What about mucolytic or expectorant?
They can take that.
Exactly. What about vaccines? Should these people get vaccines?
Yes.
Yes.
Exactly. Anybody with any kind of lung issues should take your pneumonia and your flu vaccine. Once patients with COPD, once they get pneumonia or they get the flu, it's really hard on them. So We want them to take the vaccines.
So
Okay,
I have a question
yes,
for the shocker. That I have a question
no problem.
for the cough suppressants. What if they're coughing like all through the night, they can't sleep at all? Would we do it then? Or like for a question, what do we choose?
So let's say, and I know a perfect question is about a kid, a little kid that has chronic bronchitis, and the mother wants to know if she can give cough syrup. And the answer to that question was they can give cough syrup for at night so that they can have some relief so they can sleep. Another question that I know of, which I hope I'm not going to use on the test, is a patient that just had surgery and is constantly coughing. What would you do? And some of the answers were, have them drink more water. Another one was have it suction. But the answer was to give them cough syrup so they didn't like blow their stitches. So you can use it, but are we going to use it every 4 hours? No. Okay, so we'll just give it so that the patient can have some relief. Okay? What happens in emphysema that traps the air?
Loss of elastic recoil, so the volume of the air expired is reduced.
Right. So this problem is that they can breathe air in, but they can't get rid of all of it. And that's why they'll have a barrel chest. Their body kind of compensates for that. So they'll have a big chest, and then their arms, their legs will be very, as they call it, chaotic, very skinny. Okay, what happens is that all their energy is going to breathe. Okay, so all their calories, all of their energy is for them to breathe. So that's why their legs and their arms are very skinny, but they have a big barrel chest because of all the trapped air. What are some manifestations of emphysema?
Barrel chest.
I should read my questions before I answer all that.
Progressive dyspnea, frequent coughing with clear sputum, and diminished breath sounds and wheezing.
Exactly. Where would the diminished breath sounds? Would they be in the upper or lower lobes?
The upper,
Do you think?
I'm guessing.
What do you guys think? Would your would your diminished breath sounds be in the lower lobes or the upper lobes?
Lower, is that where the alveoli are?
Well,
Would it be both?
well, eventually you're going to have both if we don't take care of them. But generally it's the lower lobes, the ones that are having a hard time for the air to get down to. Okay. How is COPD diagnosed?
ABG, CBC, chest x-ray, PFT, then the 6-minute walk test, and sometimes the serum alpha levels.
Yeah, the serum alpha level, alpha trypsin levels. The 6-minute walk, it really doesn't diagnose our COPD, but it does let us know if the patient needs oxygen or not. Okay. But definitely the PFT and also the chest x-ray. The chest x-ray gives us an idea. So we'll do the chest x-ray. Somebody comes in or having their dyspneic, we'll get the chest x-ray to see what's going on. Is it pneumonia? Is it COPD? Is it bronchitis? What's going on? Okay, when you're looking at a COPD in the slides, it shows huge chest and everything is air. You see very little shadows in the, I don't want to say shadows, but white in the lungs at all. You really don't even see many ribs. It's all you see is air. And it's a big barrel chest. Okay, what kind of medications are given to the patients with COPD?
Wait, you said the two that are specific for diagnosing COPD is chest X-ray and the CBC,
No,
What'd you say?
PFT.
PFT.
Yeah.
So some meds would be the vaccines, the flu and pneumonia,
Mhm.
long and short acting bronchodilators, ipratropium bromide, theophylline, the Dolareso, I don't know how to say the other name for it, and corticosteroids.
Okay. And what are some side effects for the steroids?
Decreased
Weight
immune.
gain.
Weight gain's one.
What was the question?
What are some side effects of steroids?
Increased
decrease-
glucose, increased white blood cell.
Yep. Increased glucose, increased white blood cell.
Did you say red or white blood cell?
White. So
Um,
if a patient comes in and say they're getting say they're getting methylprednisone and they have an elevated white count, there's actually let's calculation that we can do with the neutrophils to see if it's infection based or if it's steroid based, that increase in white count. Okay, so we have white count goes up, glucose goes up. So what about your patient that comes in that's let's say they're diabetic and they're on metformin? What do you think what do you think we're going to do to help them control their sugar?
They're probably going to be on correction insulin just while they're in the hospital on the steroids.
Right. And guys, I'm telling you, with this kind of stuff, you have to explain to your patient, because a lot of them are like, I'm not on insulin. I don't want to be on insulin. Metformin worked real well until I came into this hospital, and then I'm going to leave with 6 different diagnoses is why I'm here. But you have to explain to them, infection raises their glucose. Steroids raises their glucose. The fact that they're not burning off their sugar raises their glucose. Okay. So we have to control it. And the best way we control it is through corrective insulin. Now it's important for you guys to realize that, because your truck drivers can't be on sliding scale insulin when they leave the hospital. They'll lose their jobs. So that's why a lot of them get real freaked out when you just get out the insulin pen, and that's any CDL license. So make sure that you remember to explain to them it's just short term. Okay, they're not going to go home with it.
So what can cause the infections in the mouth and we need to rinse after?
What causes it? The steroids, the inhaled steroids. You can
Okay.
get it. You can get it with IV, but usually it's the inhaled steroids. Like I said, I haven't had anybody get thrush on IV steroids, but it can happen if their immune system's down. Okay. Should steroids be administered before bed?
Mostly in the morning.
Yeah, why?
because you want to do it with the body's normal cortisol, whatever.
So why can't I do it at night?
Your body doesn't produce it at night, usually, like the mass of it, right?
So what does that mean?
They
You
can
wanna
Make it
also
difficult
have
to sleep.
yeah.
Exactly.
For you.
Some people get really hyped up on steroids. I mean, even when you're talking about prednisone, they can feel a difference when they're on prednisone. With these, especially when you're talking about IV steroids, you know, people will feel anxious. You might see their heart rate go up a little bit. So we give it to them in the morning, and that's a patient teaching to take your steroids in the morning so that by the time it's time to go to bed at night, it is wear it off. Boy, that was good English. Wore off. Has worn off so they can sleep. Okay. That was awful. Okay, what is the goal of oxygen administration to people with COPD? Should they be 100%?
We want to keep them around 88 to 92% because too high can deplete the hypoxic drive.
Okay, very good. So 88 to 92. So say a patient, so how can I put this? So generally we sit there and like, oh, the patient's dyspneic, they're short of breath, so we're going to have to up that oxygen level. We don't do this in this case. Okay, because we can actually make them more hypoxic by having it too high. And I think that really, okay, so pet peeve number 120,243 is that when your patient is at 100% oxygen and they're still on like 5 liters. Okay, patients don't have to be at 100%. You can wean them down. With COPD, we keep them between 88 and 92. So if they are dyspneic going to the bathroom and they're at 92, well, they're going to be dyspneic going to the bathroom. Okay. These folks we can't cure. We can slow down the process, but we can't cure them and make them breathe at 95% again.
So Becky, is that what the goal is though? Like, I know those are like the levels we need to keep them at, but is that technically like the goal? Because the goal isn't to keep them from being dyspneic.
Right. So you kind of have to weigh the pros and the cons, quite honestly. People that are at 88%, that's where they live and that's where they're comfortable at, quite honestly. So whereas you, if you were down to 92%, you would feel it. These COPDers they're getting used to lower oxygen levels at a longer amount of time. So maybe when they first started to have COPD, they were at like 94. Now they're down to 92. They're not going to be as dyspneic as maybe you would be at 92%. Does that make sense? Their body's kind of getting used to it.
So they're not on oxygen at home, are they?
Well,
does it depend on how, like,
yes,
what their rate is?
So if they're not on oxygen at home, then we're going to try to wean them off of oxygen at the hospital. If they're at 2 liters at home, we're going to try not to get them higher than that 2 liters while they're in the hospital. Does that make sense? So we're going to keep them status quo. But to sit there and say that, well, they're at 3 liters at home, so we're going to get, when they leave, they're going to be down to 1 liter. It's usually not possible.
So is there a certain amount like that you can give them? I've heard like you shouldn't go above like 4 liters.
So if a patient is acutely hypoxic, so maybe they're at 83%, you will see us give them a non-rebreather or, maybe 10 liters and a high flow cannula, but not for that long, just to get them over that hump. Generally, you'll hear that we don't go over 4 liters when it comes to COPDers. That's a general base. Have I seen above it? Yes. So to answer your question, Alexa, sometimes we try to get them back to the base level, but are they going to be to the point where they're going to be dyspneic when they walk? Yes, unfortunately. it's just the natural occurring part of the disease. And some patients might not even walk out of there. Maybe they walked in, but they're not going to walk out of there because their lungs are so badly damaged. But if they came in and they're on, walking at 95%, then we're going to try to get them back up to 95%. We're not going to leave them dyspneic. I know that doesn't really answer your question, but I think it's on a case by case basis. But the biggest thing is we have to teach them, like bundle their care. If they're going to, and this is kind of odd, but if they're going to go to the bathroom, brush their teeth while they're in the bathroom. Don't brush your teeth, come back, then go to the bathroom and then come back to bed. We want them to be able to adapt so that they can get the most out of their life that they can. And that's the same thing, like even with like patients with angina. There's some people that are walking around that are going to have chest pain the rest of their life. There's nothing we can do about it. They're just going to have chest pain. And we got to teach them how to live with that. And the same thing with COPDers. COPD, and don't think, I love these commercials with COPD. These people are biking and they're fishing and they're nice and well and nourished and tan and they're with their grandkids and everything's wonderful, and it's a lie. Okay. Some people, yes, are like that. Other people, it's an ugly disease. I remember we had one guy that was 32 years old and was in end stage COPD. Like you could put his wrist around your fingers. Like that's how skinny he was. Barrel chest, like that guy in the picture, real big chest, but everything else was so skinny. I mean, it's not, I don't want to say glamorous, but those people on TV look wonderful compared to some of the patients we had with COPD. And some of them are even, I don't have COPD. Don't have it. Can't prove it. One guy told me, can't prove it. I don't have it. You can't prove it. Well, yeah, I can. But anyway. Does that help at all, Alexa?
Yeah, it does.
As I went on a tangent. Okay, what is pursed lip breathing and why does it help? Anybody? Bueller?
It helps to keep the airways open longer so that you can remove the air that's trapped in your lungs by slowing down your breathing rate and relieving shortness of breath.
Yes, it allows you to exhale longer. Okay, so we teach pursed lip breathing. If patients are out of breath, we teach them how to do pursed lip breathing so that they can exhale longer. Okay, what education will slow down the progression of the disease? Y'all should know this one.
Stop smoking.
Yep. Stop smoking. What other parts of the disease do we sit there and tell them to not smoke about? And how do I put this? What other factors should they stop smoking? Because of this is what? What'd you say? Did you say crack? I'm just gonna pretend. Okay, oxygen. If they're on oxygen, they should not be smoking while they're in oxygen. Remember the couple times going into Walmart, there would be somebody with oxygen sitting outside with their oxygen taken, smoking. Yeah, not a good idea. Okay, but definitely we can slow down the progression of the disease by telling them to quit smoking. What is pulmonary hygiene?
Hydration, effective coughing, percussion, and postural drainage.
Yes, that's what, whenever somebody says, you'll see notes, progressive pulmonary, or not progressive. What is it? What is it? What is the word? Aggressive, not progressive, aggressive pulmonary hygiene. And that's what we're talking about. We're talking about aggressive pulmonary hygiene because we want them up. We want them to be able to cough, deep breathe. We want to give them fluids so that we can help them breathe better. What kind of diet should COPD patients be on?
High fiber, high calorie, high protein, low sodium, increased fluids.
So when you say high calorie, so we're talking gummy bears.
Carbs.
No, complex carbs.
Okay, so what's a complex carb? Would it be pasta, morning, noon, and night? I say that's a good idea, but I'm all for pasta. So the reason I ask you is because there's a lot of diet questions, and the diet question is, you might come across a question that would be, a patient with COPD. I'm trying to think something. By the way, diet questions are usually chicken. It's always chicken. Always pick the chicken unless it's fried chicken. Then don't pick that chicken.
It's
So
always like steamed broccoli and grilled chicken breast.
that's it. That is it exactly. So a patient with COPD, what would you show? What would they eat? And it might be a hamburger, French fries, or it might be, you might see an option, high carb diet. When carbs are important, but the complex carbs are better. Okay, so just keep that in mind. What else other than diet? What else should they do?
Small, frequent meals.
Why?
Because it takes a lot of effort for them to be eating, like, because they can't breathe as well. So whenever you do small portions at a time, it gives them time to breathe.
Exactly. And you remember I told you about that one patient I had that she couldn't breathe, and every time she would just lift her she would lift her spoon up, she would desat. I was watching all you guys with your cats, and I was like, oh, I wonder where my cat is. She must have mental telepathy. Now she's being a pain in the butt. But yeah, they can desat really easy while they're eating. So it should be several small meals and even snacks in between. What are complications of a lung transplant?
Question. So
Answer.
Karen said to avoid foods that cause gas, like broccoli. So we would not choose broccoli, right?
Pick the most correct. Right, Becky? The most correct. They're all right.
Yeah. So, I mean, if it was the difference between steamed broccoli and hamburger and French fries, I would go with the steamed broccoli. So you have to kind of like weigh your options. Although broccoli would cause some people to have gas, it might not cause everybody to have gas.
What if it was a select all that apply? So
Oh,
like
you're
they
killing me.
and things like that.
I would still think that steamed broccoli would probably be a good one to have. And yes, it does cause gas, but it's steamed broccoli, and where can you go wrong with steamed broccoli?
Yes.
Gas. Okay. What are some complications of a lung transplant?
Rejection, infection.
Yeah. Rejection,
Bleeding.
infection. What was that one?
Bleeding.
Bleeding. Who can get a lung transplant?
Not the smokers.
Yeah. What about a past smoker?
If they're
Yes.
not currently smoking.
Exactly. So in case you didn't, so this is what happens. A lung comes available and they call everybody that's good for that lung to the hospital. So they'll call 3 different patients to the hospital for that lung. They'll pick the best patient for that lung, the best tissue match, the best labs. If they find that you smoked, then like, even the last week, you are null and void for that lung. Okay.
So if the patient didn't tell you that they smoked, like they kept on denying it, and you can't smell it on them, what labs prove that they did?
Probably none.
Okay.
There'd probably be no labs. I mean, it's a bad scenario. So how about liver enzymes if you're going for a liver? Okay. And they do an alcohol test. And I think that was on a Good Doctor. I think it was on the Good Doctor.
Yeah.
It was a liver transplant. She had 1 glass of wine at her daughter's graduation, and they did an alcohol test and she failed. So that 1 glass of wine, they only gave her 3 months, and she would have to get another 6 months to get back onto the transplant list. So they knocked her off that list by having that 1 glass of wine. If you go in for a lung transplant, they'll check everything to make sure you're the proper candidate for it. A friend of mine went for a kidney transplant. I think there was 3 different people that came, and he didn't make that kidney. So they told him to go home. As they were walking out the door, another kidney came available. So they walked back in, and he was a perfect match for that kidney. So it was kind of like, talk about a roller coaster of emotions.
How does a kidney just like become available? Like
Girl,
just
I don't
someone
know.
died randomly and they're like, here's another kidney for you.
Well, I
Look at
guess
the
that's
timing.
I guess that's how it goes, though. It just, and what happens though is like, Mid-America Transplant Services has an ICU right outside Barnes that has 4 beds. And what they'll do is they'll keep people alive in that ICU unit until all the teams get there to harvest the organs. And that's what that nurses are, supply that staff to keep those patients open until all those teams from everywhere come and harvest those organs at that place. It's just, it's interesting, really depressing at some point. I went to a seminar where they talked, and like this one guy had twin 8-year-old girls, and the 8-year-old girls came to the place to say goodbye, and they gave them teddy bears to let their daddy hold. So they put the teddy bears in that guy's arms, and then the kid said goodbye, and they started harvesting their organs. It's kind of gruesome if you think about it, but she was very proud of what she did, and they saved lives, but the other end is not so heartwarming, I guess.
Can they feel pain at that point?
Yeah, I imagine they can, because that's why you get morphine during surgery, because you can, even though you're out, you can still feel pain.
Do they get morphine? Or
Oh,
do
I'm
they
sure they
not?
do.
Okay, good.
I'm sure they do. I can't see, they're not barbaric in that aspect.
So Becky, what other patients besides smokers can't get the
Smokers
lung
can.
transplant?
Smokers
Well,
can.
current smokers.
Okay, current smokers, anybody that has a high white count. So if they have any kind of infection, if they have a cold, so anybody that's not less than ideal will not get that kidney or that lung. So you can be a patient with cystic fibrosis. You can be a patient that was a COPD. But if you are a patient that had congenital defects and your white count's elevated, you're not getting that. Because if you think about it, you're going to be taking all those immunosuppressant medications and you have a cold, what can happen? So you want to give the best person that kidney, or I'm sorry, lung. I'm on kidneys. Is cystic fibrosis genetic?
Yep.
Very much so. Okay, it's very when I had my last child, I was in advanced maternal age. I was worried about having a kid with they do that test and it said that I possibly had a Down syndrome baby. So I had to go to St. Mary's Clayton for that deeper ultrasound. Sat down with a genetic counselor and she's like, what are you worried about? I'm like, well, Down syndrome kid. And she goes, what happens if I tell you? And we did the little genealogy. She goes, I'm more worried that you'll have a child with cystic fibrosis. I'm like, what? My cousin has a child that has cystic fibrosis, so I was more likely to have a child with cystic fibrosis than Down syndrome. That's how genetically linked they are. Okay. What protein do they lack?
CFTR.
Yeah, CFTR. And what systems does that affect?
Like
Respiratory,
everything.
GI, reproductive.
Okay. So what's the pathophysiology of the respiratory system? So how does it affect the respiratory system? What are you going to see?
Excess mucus production and the inability to clear secretions.
Yes. So that's the biggest part with that, is they have continuous mucus production. Okay. I'll get back to that. What about the GI system?
Pancreatic enzyme deficiency, impaired digestion, elevation of sodium and chloride in the sweat.
Okay, so they're having problems with the pancreas. So what kind of signs and symptoms is that my next? I don't even have it, do I? What signs and symptoms of GI would they have?
Don't they have like really fatty bowel movements, like really gross looking, nasty, horrible?
And what's that called?
I don't know. It's
Frothy.
just fatty.
No, setoria.
Oh yeah.
That word.
That's the word. Nasty, smelly, greasy bowel movements. It sounds better when you say setoria.
So I have a question.
Yes.
Okay. Me and Emily were talking to Karen, and I'm pretty sure that this was the one. Emily can correct me if I'm wrong, but the pancreas can produce enzymes, but the ducts are blocked. So it's producing it, but it just can't get anything to move, kind of.
I almost would say narrowed. So it's having a hard time. I wouldn't say totally blocked. I would say narrowed. Okay. So what can we do to help that nasty, smelly poo? What do we do? Do we say, just let me know that you went to the bathroom so I don't follow you? It's not very therapeutic.
Air fresheners. I'm joking.
What's that one about poop? So you
That
don't smell my
poopery that
poop?
you like spray in the toilet before
Yeah,
or
that's
whatever.
it.
And the lady's like, do you have issues with this?
Yeah, is that what we do? Give them a prescription for that stuff? What kind of medication do we have for that? Do we have any medication?
We do. I don't remember what it's called, but they can take a pill or they could sprinkle it, like if it's a kid, you can sprinkle it on their food to help that get absorbed, right?
Right. It's there's a medication called pancreatase.
That word.
That word. They can take it right before they eat. That can help. So if that's the problem, so they're having gassy, smelly poo, what kind of signs and symptoms do you think they'll have with that gassy, smelly poo?
Abdominal pain.
Abdominal pain. So what do you think we would know if that pancreatase helps?
Decreased abdominal pain.
A decreased abdominal pain, decrease smelly, stinky poo. Okay, so that's one thing we can help with. Okay, of course, if they still have the abdominal pain and the stinky, smelly poo, we know that we got to help them. Okay, so that's pancreatase. What else? So that's GI. What about endocrine?
Small
liver
stature.
failure.
Yes, very small stature.
Diabetes.
Well, diabetes. Of course, well, I mean, the small stature and the diabetes. Also, they have a hard time. Women will have a hard time reproducing, and the men will have a hard time reproducing also.
And liver failure, right?
Could possibly, yeah. And that's all with that the bile ducts backing into the liver and the pancreas. So, how is it diagnosed?
Analysis of the amount of chloride in the sweat.
Yeah, so we do a sweat test is basically how they do it, is a sweat test. And I guess sweat tests are pretty common anymore. Seems I've heard of several people taking their kids to get their sweat test. So with the sweat test, obviously there's a lot more salt coming out in their in their sweat, right? So is that a problem? Why is that a problem?
They sweat more, it means that there's more sodium leaving and more water.
Okay. And is low sodium a problem?
Yes.
Okay, so what are we going to tell? What's some patient teaching with the sodium leaving their system?
You would actually want them to eat more salt.
Okay, and you want them to, I mean, imagine saying that. Have some more pickles. Have some more Diet Cokes, right?
Here's some McDonald's French fries.
Yeah. Ask for extra salt. What time of year do you think is really a problem for these folks that have cystic fibrosis?
Summer.
Summer is rough. We have to be very careful with them in the summer. Okay.
How do they get the sweat test? Do they just have the kid run, or like, what do they do?
Actually, I don't know. I'll get back to you on that. I doubt if they'll be run because usually the sweat tests are done like with 3-year-olds, 4-year-olds. They're very young. What they'll have is they'll start having symptoms. Maybe they'll have, recurrent bronchitis. And so they'll start checking off the marks like, okay, let's try cystic fibrosis. And they'll check it off that way.
So the Cystic Fibrosis Foundation says that a colorless, odorless chemical and a little electrical stimulation is applied to a small area of the arm or leg to encourage sweat glands to produce sweat.
There you go. Well, thank you.
Mm-hmm.
And that's there. Is that you said that's cystic
I just
fibrosis?
I googled how do you get a sweat test, and then it came up like the Cystic Fibrosis Foundation.org. and it like goes through this whole thing, how it's done and everything. It's got like a little baby getting it.
Aww. Well, I guess that little kid cannot run on a treadmill. For sure. Okay. So gastrointestinal, what's the usual age for patients with cystic fibrosis? It used to be, let me go back. It used to be teens. Like teens were the highest that they could get, like 16, 17. That was, we were doing good. But lung transplants, new medications that help slow down the progression of the disease help very much patients to stay a longer life. And in fact, I'm going to put up a video of a girl, can't remember her name. You can tell it's the end of the semester. Well, it doesn't. What was her name? Anyway, she was an outspoken advocate for cystic fibrosis. I'm going to post it though. Very good at how you look into how you can, the day in the life of a patient with cystic fibrosis. Okay, it's very good, and I will post it for you guys to watch after the quiz tomorrow.
So for the quiz, do we need to know the life expectancy?
No.
Okay.
But how do they ultimately, what is the ultimate that's going to happen with these folks?
They need a lung transplant.
They need a lung transplant. And you guys have all had Brandy, right? For speech? No? No. So Brandy, she's a speech instructor here at KC. She had a double lung transplant. And she's like, and I remember her whenever I was going to school, because the cardio instructor's like, Brandy, the one girl across the hall, she has cystic fibrosis. Then when I came to teach here, she's already had her lung transplant. But very small stature. She is, small stature, very skinny. Okay. But she had her lung transplant 5 years ago, I want to say. Did she say?
So they have to get those like a lot, like every 10, 15 years or something? Or is
Yeah,
it like,
well, and you know what? You think that lung transplants, you get them and you're good to go, right? But she has to constantly go back for testing. She has to constantly go back for infusions and things like that.
So can an organ reject years after they have it still? Okay.
I imagine they can. Because when you're talking about organ transplant, you're on anti-rejection drugs pretty much your rest of your life. So yeah, those organs can wear out, unfortunately. So anyway, let me think. There was something else I wanted to talk to you guys about. So what do we do for the respiratory part of a patient that has CF?
Don't they get percussion, like cupping and stuff for the vest?
Yes, they'll have percussion vests to help get that mucus moving, so they're able to cough that mucus up.
postural drainage
Yes,
and oxygen therapy?
postural drainage and oxygen therapy. Okay. We want them to be able to so expectorants also, mucolytics. Should they have their vaccines also? Definitely. trying to think if there's anything else about cystic fibrosis patients.
Are there any other meds that we should know, like other than the expectorants, mucolytics, and vaccines?
No, I don't think so.
So what is like the hypertonic saline inhalation?
So that helps with getting, it basically helps it thin the secretions, the mucus. So they're able to cough it back up.
Is that with all CF patients, or is that just selective? Like who needs it most, and like,
I imagine, yeah, case by case difference. Cool. I wish I remember that girl's name. I have to throw that up there for you guys to watch after the quiz, not before. Don't let this, don't let open note fool you guys. Okay, so because sometimes it's hard to find the answers that quickly. Just use it as you need it.
how many questions, give or take, do you think is
10.
gonna be? 10? Okay.
We can still use our slides, right? Like not just our study guide.
Yeah.
Okay.
You can use whatever you want.
So it's just over the infectious and inflammatory tomorrow,
Yeah,
right? Like none
that
of this
lecture.
information is going to be on it. Okay.
What was that?
Like none of this information that we covered
No.
today is going to be on it. Okay.
That would have been too much. Quite honestly.
So I have a question for the test. We're doing lockdown browser on our laptop and then zooming on our phone, correct?
That's correct.
So what if we need to ask a question because it stops your camera, as we found out when it stopped mine and I freaked out
Well, can't you ask a question?
verbally?
Yeah.
Okay, cool. Just checking.
I have a question about the test too. We did like a study guide over ABGs, not just the tic-tac-toe problems, but you had like, will there be actual like questions about the ABG stuff?
Yes.
Okay.
So it's everything on respiratory because we did not test anything on respiratory. So it's a lot of information, right? But a lot of the information you already know. PEs, how do we stop, what do we do if a patient has PE? What kind of medications are we going to give them? Are you like, no, don't even go there. I don't even want to think
Don't do
about
that now. Don't. Just don't.
Okay, well, let me just give you a hint. We're going to do anticoagulant therapy. So we're going to have heparin, right? And we're going to give them Coumadin. We've been there, done that a couple of thousand times. We've done it with AFib. We've done it with DVTs. We've done it with pulmonary or with peripheral vascular disease. Okay. What else is there? I mean, like the chest tubes are new to you guys. Upper respiratory, but everything you guys had quizzes on already, and you have the study guides.
That doesn't always mean much, though.
I know, because nursing questions aren't just coming off the study guides, right? So I'll see if I have anything in my little box on ATI that I can give you some more questions to help you guys out on.
So
Okay.
We're doing a Zoom though on Wednesday night, aren't we?
We
Or
are.
did I don't know. I thought I saw that. Maybe not.
Oh my.
Maybe I'm not.
If you have questions, so if you have questions, so let's do
Maybe I'm
this.
thinking, are we doing something before the final? Maybe is that what I'm thinking? I thought I saw somewhere that we're doing a Zoom after one of my clinicals.
Well, we're gonna
Monday.
do a Zoom next Monday
That might
for
be what I'm thinking of.
to go over the quiz or for test review for
That's what I'm
Thursday's
thinking.
test review. So we are doing a Zoom then. So that's next Monday. And if you have, and I would say if you have any questions, that would be a perfect time to ask any questions on any of the information is on Monday. I'll remind you guys of doing that.
Are we doing anything Tuesday like when we would usually have class?
No, I was thinking that maybe I'll throw a Zoom together after the quiz so we can go out over the questions. Maybe I'll have one at 10 o'clock or something like that so we can go over the questions. But I want to see how you guys do first.
Do you often pull your questions from ATI? Like, would doing the learning systems help, or would it just, well, it'd help, but
It would
Like, it would-
help.
okay.
I think it would help. Girl, I grab my questions from wherever I can find them. I can't tell you how many test banks I look through. How ATI, FA Davis, you know, like I said, I pull them from everywhere. I figure it's pretty much because I don't have the imagination to be. I only had one question. Well, two questions I pulled out. I made myself, but that was it. And that was it. So
Are we going to have a study guide for the final?
well, aren't all these study guides part of a study guide for the final?
A narrowed down study guide for the
Oh
final?
dear Lord
great.
in heaven.
Wishful thinking?
Or maybe like even, I would take even like this many questions you can expect, give or take, on test tubes or something.
Eh.
That doesn't help. You still have to study everything.
Fair point. I'll take anything though.
Ugh. Yeah, I can do one.
Thank you, Becky.
Thank you.
Does anybody else
Thank
do study guides?
Lisa's doing one for farm.
Yeah. Lisa did some for OB too.
Nicole's doing one for mental health.
We'll get you a Christmas present.
Yeah, I won't see you again, so. Yeah, I'll do it.
Tanisha,
So listen,
are you?
what?
Never mind.
So let me think of when I can get this done. Thursday's the test, so it'll be probably, so tomorrow. So I will try to have it done Thursday night for your study guide.
Thank you.
And you farm people have your final, what, Monday or Tuesday?
Tuesday.
Tuesday. So I'll have it done Thursday. I know it's hard getting those two tests. That's why my final's on Wednesday, so you didn't have it both in the same day. Because I think that would really suck.
Thank you for
And
that. That would suck.
your Wednesday group still has clinicals Monday, right?
Yes. Well, and you know what? Quite honestly, if it's like today, there was one patient on the floor that was not COVID. So we had, in my Monday group is like half. So I reached out to other areas of the hospital to farm you guys out to. And the one patient that did come in, it was funny, they came into 20, and I was like, are they COVID? I said, oh my gosh, we got a patient that's not COVID. I was like all excited. And the ER nurse is like, yeah, they, I didn't get any report that they were COVID. I'm like, well, isn't that awesome? It's a shame because I had to farm my students out, And she's like, well, that's one patient he had. And wouldn't you know, he came back COVID positive. They swabbed him and he came back COVID positive, and we never thought he would have been COVID positive. And I'm kind of glad because he was cranky, very cranky. So I'm kind of glad we didn't take him because, oh my God, he was cranky. Oh dear Lord, cranky, cranky, cranky. He went AMA on two hospitals. He went AMA. Or we are the third hospital. He's trying to make it down to Texas. I don't know how many hospitals he's going AMA on to make it down to Texas. He has a ways to go. So I'm hoping he's still COVID positive come Wednesday because he cranky.
With him being COVID positive, can he sign out AMA?
I
Will
guess
they
he,
let him do
well,
that?
I don't know. You know what? That's very
I would
ethically.
think that would be a public health issue.
Well, there's COVID positive people walking around.
Yeah, they can't like keep them like it's a prison. Like if they want to leave, we can't keep them there.
Remember that those nurses that came back that were Ebola? That had Ebola and they were like trying to keep them quarantined and they said you had to stay and they're like that was against their civil rights to get up and move, you know, and it was a big darn deal. You know, you're talking touchy situation if you tell people they can't leave. Very touchy.
So Becky, if there was only one patient on the floor that you guys could have, how did that even work?
So I only had 4 students today.
Oh.
So somebody went down to stress test, somebody went to ICU, and then ICU stress. One went upstairs.
So is that including 3200 and 4200, or was that just one?
That was just 3200. 4200 has 2 run like groups up there. So basically I went and I found a nurse that did not have any Red Lake students because they kind of get pissy when I show up there because I know what I'm going to do.
So did you just try to like go between the floors then, or did you stick on 3200?
I stuck on 32. Luckily, Jaden's patient went down to cath lab and ended up with 3 stents. So she was able to see that. So it was a good patient for her. 42 had some decent patients on there. I think Wednesday they only have maybe 1 Red Lake group, but I've reached out to surgery. I've reached out to cardiac rehab. I've reached out to the procedure center. So hopefully between all of them, we'll get you guys somewhere. It won't be on the floor. I know you guys are so upset that you won't be able to be with me and have the ability of getting a 1, right?
So will we, if we're not with you, are we just going to basically shadow a nurse then?
No, they'll
Or
let
would
you.
we-
No, they
Okay.
let you pull meds and
Okay.
do meds and dressing changes and the full gamut. No intubations and no lumbar punctures.
So
That
we
you know of.
Yeah, and if they do, don't tell me. Please don't put it on your evaluation.
So when we're in the room scanning meds, do we have to scan under our nurse's name then since you're not there?
Yeah, you should.
Okay.
If not, then I always go back and talk to the nurse to make sure, just liability reasons.
I've always assumed, but
It's better just to ask. So hopefully I'll get you guys. I mean, I think I have everybody coming tomorrow or a Wednesday. So hopefully we'll find some things for y'all to do. If anything, it'll be a good time to study for the test. Okay. It just sucks. I'm just hoping come January, the vaccine comes out and we get some patients.
so do we know if students are gonna have to take that? Or is it just like the first round and then second, whoever gets
I
it?
don't know. I don't even know if we're like in the radar right now. Quite honestly.
Are we good to go, Becky, if we are done with the review?
Yep, we're good to go.
Thank-
No
Thank you.
problem. If you have any questions, let me know, okay?
Thanks.
See y'all.
Thank you.
No problem.